Hello, and welcome to our first episode of Practice Pearls Podcast, an educational podcast about menopause for clinicians in primary care and OBGYN.
Let's start by introducing ourselves. I'm Kim Vesco. I'm an obstetrician gynecologist. I practice, teach, and do research at Kaiser Permanente Northwest in Portland, Oregon. Our studies at Kaiser, as well as national surveys, suggest that many healthcare professionals are not getting sufficient training in menopause medicine. As a result, women aren't getting the menopause care they need.
I'm your second host, Amanda Clark, a urogynecologist and menopause physician also in Portland, Oregon. I practice, teach, and do research in two places, Kaiser Permanente Northwest and Oregon Health and Science University. As a urogynecologist, I primarily see women in the menopausal age group. Listening to their concerns about menopause has been a daily part of my practice for more than 30 years.
And I'm your third host, Tovi Anderson, a family medicine physician. I'm a recent graduate at the Family Medicine Residency at Oregon Health and Science University. I currently practice at Kaiser Permanente Northwest in Portland, Oregon, and I'm a member of the teaching faculty. In my new practice, I'm seeing a lot of postmenopausal women who struggle with menopausal symptoms without awareness of their many options for treatment.
So why are we making a podcast about menopause?
Because the recommendations for menopause hormone therapy have changed. We've designed this podcast to give you up-to-date information about the management of menopausal symptoms. Given that 1/3 of women's lives are spent in the postmenopausal years, it's a vital part of every women's health curriculum.
For 15 years, the recommendation for hormone therapy for menopausal symptoms was to use the lowest dose for the shortest period of time.
That recommendation was based on the findings of the Women's Health Initiative, the WHI, a blockbuster study of women's health that was begun in the 1990s and first reported in 2002. New research has refined our understanding of the WHI and led to an updated axiom for hormone therapy: to use the appropriate dose, by the appropriate route, and for the appropriate amount of time.
The newest guidelines state that hormone therapy may be safely prescribed to improve quality of life related to menopausal symptoms when the therapy is initiated early. So that's for women younger than age 60 or within 10 years of menopause.
Today's episode is the first of 6 short podcasts that will provide you with the basics you'll need to care for women with menopausal symptoms.
In these episodes, we will review the evidence that informs our counseling of women about the menopause transition and treatment options for menopausal symptoms. We will cover the evidence that comes from landmark studies of hormone therapy, such as the WHI and the ELITE trials, as well as new knowledge about how women experience the menopause transition.
We will provide practical information about prescribing hormone and non-hormone therapy, and discuss the evidence about bioidentical and compounded hormones and herbal remedies.
We will also discuss how and when to consider discontinuation of hormone therapy.
And we will address treatment of the genitourinary symptoms of menopause with local vaginal therapies.
We will also discuss the evaluation of abnormal bleeding as it relates to the menopause transition.
We'll present typical cases that we see in our practices, but please note, none of the cases that we present are real patients. Instead, they represent compilations of the typical patients that we've seen.
When counseling our patients, we must also take into account that women are exposed to a diversity of opinions and likely some misinformation about menopause before they arrive in our offices.
With that in mind, we will alert you to some of the misinformation about hormone therapy that exists in the media and on the internet. And we'll address some of the cultural expectations that influence women's choices about managing menopause.
The new clinical guidelines for hormone therapy were published in 2017. They outlined big changes in our approach to menopausal hormone therapy compared to our practice in the 15 years after the first WHI report released in 2002. Physicians who completed their residencies during the 15-year span, when recommendations were to limit hormone therapy use, may not have had much experience with prescribing hormone therapy.
Our goal for these 6 episodes is to provide you with up-to-date information regarding menopause and treatment of menopausal symptoms, so you will feel comfortable talking with your patients about their menopausal symptoms as well as their treatment options.
We've outlined a big agenda, so let's get started. What exactly is menopause? Biologically, menopause marks the end of the reproductive phase of a woman's life. All women pass through the menopause transition, but individual women's experiences during the transition can vary broadly.
The classic symptom of menopause, the one that bothers women so much, is the hot flash. Hot flashes are medically described as vasomotor symptoms. I was taught that hot flashes usually last for 1 to 2 years and then resolve.
We now know that this is not what happens. We've learned a lot about women's actual experiences through the menopausal transition from something called the SWAN study. SWAN is an acronym for the Study of Women's Health Across the Nation.
The SWAN study was an observational study in the United States that enrolled more than 3,000 multi-ethnic midlife women and followed them through their menopause transition. The study began in 1996, ended in 2013, and followed women for an average of 13 years.
The SWAN study debunked a lot of our ideas about menopausal symptoms. When we used to say that hot flashes occur for 1 to 2 years, it was really only true for about 1 in 5 women.
The SWAN study showed that women experience hot flashes for 7.5 years on average, but the duration of hot flashes can be even longer than that for certain racial or ethnic groups. For example, they may last for 10 years among African American women.
From the SWAN study, we know that 95% of women will experience menopause between the ages of 45 and 55, with the final menstrual period occurring on average around the age of 51 or 52.
And that hot flashes often begin 3 to 4 years before the final menstrual period and then continue for another 3 to 5 years.
We also learned from the SWAN study that 25% of women have hot flashes that never go away. The investigators coined a term for this unfortunate group of women, the superflashers.
So when a woman says that her hot flashes have lasted for decades, there's evidence to support her experience.
The causes of hot flashes are not fully understood, but we do know that everyday small changes in body temperature trigger a rapid and overly robust response. The body's thermostat becomes too sensitive. Blood vessels in the skin dilate rapidly, most often in the face and chest, resulting in hot red skin and a sensation of intense heat.
A hot flash may last anywhere from 2 to 30 minutes. Sometimes a hot flash is perceived as a palpitation. A woman's heart rate may rise by 15 beats per minute. Profuse sweating during the hot flash may lead to drenched clothing. The initial sensation of intense heat may be followed by feeling cold and clammy.
When hot flashes occur at night, women describe them as night sweats. These episodes disrupt sleep for the woman and for her sleep partner. Women are awakened by feeling too hot and they throw off the covers. The sweating that follows drenches their bedclothes, requiring a clothing change and often multiple changes through the night. Hot flashes at night can be particularly disturbing to a woman's quality of life.
Of course, the disrupted sleep causes fatigue and irritability, difficulty concentrating, and sometimes even depressed mood. The symptoms are very similar to those of clinical depression.
Distinguishing between menopausal symptoms and clinical depression is often challenging. If the symptoms are temporally related to sleep disruption, then our diagnosis should lean more toward menopausal symptoms.
After the menopause transition, postmenopausal women are no more likely to be depressed than before menopause. But it is also important to know that the transition or perimenopausal phase is a time of increased risk. Women with a history of major depression are more likely to have a recurrence, and new onset depression is a bit more frequent as well. Clinicians need to consider both diagnoses carefully when evaluating menopause symptoms.
Many women complain of weight gain at the time of menopause. Determining the independent impacts of aging and menopause on weight gain is a topic of active investigation.
The SWAN study examined weight and body composition changes during the menopause transition. The researchers didn't actually see an increase in the rate of weight gain with the transition, but women tended to lose lean body mass, which was replaced with fat mass.
The additional fat mass is redistributed centrally to a woman's midsection, leading to an expanding waistline that isn't healthy nor welcomed. On a positive note, there is limited evidence that hormone therapy reduces this redistribution.
With the effects of estrogen loss on the vagina and vulva, women may also have to contend with symptoms of vaginal dryness, irritation, and painful sex.
And as the urogynecologist on the team, I'll note that urinary frequency, dysuria, and recurrent urinary tract infection are often worsened by low estrogen levels. These urogenital symptoms don't resolve, but instead worsen with time after menopause.
Women most often attribute urogenital symptoms to normal aging and don't report them as a medical problem, which is unfortunate because vaginal estrogen therapy is quite safe and quite effective. We'll delve into these details in a later episode.
So let's switch gears and discuss evaluation of menopausal hot flashes. Toby is going to present our first patient.
My patient is a healthy but very frustrated 52-year-old woman. She is a busy mother of 2 teenagers. She works full-time and she has elderly parents who are beginning to decline. She's in good health. Until age 50, she had regular 28-day cycles with moderate flow. After age 50, she started to miss a few periods, with the last bleed occurring about 8 months ago. She's had hot flashes for over a year, but they are worsening. She is most bothered by night sweats that interrupt her sleep. She dresses in layers and has tried cooling yoga with little benefit. She reports being very tired, so much so that she can't concentrate or think clearly. She had hoped to manage her menopause symptoms naturally, but is now interested in considering other treatment options.
Her presentation is common for women undergoing the menopause transition, with menstrual cycle changes corresponding to the onset of vasomotor symptoms. She hasn't met the definition of menopause, though, which is the cessation of menses for 1 full year.
Let's take a moment to review definitions of some of the terms that can be confusing. A woman is said to be postmenopausal 1 year after the final menstrual period.
The menopause transition is said to begin when the menstrual periods become irregular and lasts until the final menstrual period. This phase doesn't have an exact or clear beginning and may last from 4 to 10 years. Perimenopause begins with the menopause transition and lasts until 1 year beyond the final menstrual period. Clinically, the terms menopause transition and perimenopause are often used interchangeably.
The term menopausal means having to do with menopause in general. It doesn't refer to a particular stage. Menopausal hot flashes mean hot flashes at any stage of menopause.
But when considering treatment of symptoms, we don't need to wait until a woman has met the definition of menopause or has stopped having menses to begin treatment. Having classic symptoms near the age of menopause is sufficient.
There's something else that comes up with many of my patients. Many patients seem dissatisfied with only a clinical diagnosis of menopause. They often insist that I check their hormone levels to help assess their symptoms.
Patients often ask me to do this as well. However, testing is not necessary, and it isn't even helpful. I tell women that I already know that their hormone levels have a lot of ups and downs just because of the symptoms they describe. Measuring serum estrogen and progesterone provides only a single snapshot, and that doesn't tell us much about the woman's current symptoms or what to expect as she proceeds in her transition.
Performing lab tests to assess for menopause is most useful when assessing menopausal status in a woman who had a premenopausal hysterectomy without oophorectomy, and for diagnosing primary ovarian insufficiency, which used to be known as premature menopause.
The most common test used to assess menopausal status is follicle-stimulating hormone, or FSH. FSH becomes elevated after estrogen levels decline, but among women who are still having periods, it doesn't predict when the last menstrual period will occur.
So our assessment of Tovi's patient is that she's clearly perimenopausal with bothersome symptoms. She's a good candidate for hormone therapy based on the newest guidelines that support the safety of hormone therapy when started early. She's within 10 years of her menopause transition and younger than age 60. And while we have several treatment options to offer her, we can tell her that there is very strong evidence to support the efficacy of estrogen for hot flashes. A Cochrane review of 24 studies that included more than 3,000 women reported that systemic estrogen therapy was associated with a 75% reduction in the frequency of hot flashes, as well as a marked reduction in the severity of hot flashes.
For completeness, we will review all of her options, but not in this episode. In upcoming episodes, we will cover the risks and benefits of hormone therapy, discuss which non-hormone therapies have been shown to be effective, and we'll talk about the practical aspects of prescribing both of these types of treatment regimens.
Before we conclude this episode, we'd like to mention a few key resources for you and your patients. The North American Menopause Society, or NAMS, is a multidisciplinary medical society that is focused on menopausal care. The society publishes clinical guidelines and a variety of educational materials for clinicians and women. The NAMS website is easy to remember, menopause.org.
NAMS has also produced an app named Menopro, Menopro, that provides a decision support tool for hormone therapy. The app provides quick access to the clinical guidelines and other resources that can be very helpful in a busy clinic.
The Endocrine Society also has information focused on menopause. It publishes clinical guidelines and educational materials for clinicians and women. And the American College of Obstetricians and Gynecologists has published several practice bulletins on the topic of menopause.
To wrap up, let's go over some of the key points from the episode. First, the SWAN study showed us that menopausal hot flashes last much longer than previously understood, typically from 7 to 10 years. And for about 25% of women, the super flashers, these hot flashes never go away. We discussed that hormone therapy is not only the most effective treatment for menopausal symptoms, but also that it's safe to use in women under age 60 or within 10 years of the last menstrual period.
In the past, negative reporting about hormone therapy left women and their healthcare professionals with the impression that medical science had little to offer women for their bothersome symptoms of menopause. But recent research has given us many options to help our patients, including a return to less restrictive prescribing of hormone therapy, as we did before the initial WHI reports. We look forward to informing you about the positive changes.
Please tune in for our next episode when we will talk about the Women's Health Initiative and our current understanding of the risks and benefits of hormone therapy.
This is Amanda Clark
and Kim Vesco
and Tovi Anderson.
Thank you for listening to Practice Pearl's podcast, Menopause.
All cases appearing in this work were developed to highlight common clinical scenarios. Any resemblance to real persons, living or dead, is purely coincidental.